Firstly, my name's Susan Hillier and I'm the Dean for Research at UniSA in Allied Health and Human Performance. And I'd like to acknowledge that I think for most of us, we're meeting today on the lands of the Kaurna people, and that we pay our respects to the elders past, present and emerging, and acknowledge the ongoing connection to country. So I'm also really delighted today to present two absolute stunning researchers from UniSA. Associate Professor Nicole Pratt is going first. She's a Professor in Biostatistics and Pharmacoepidemiology here at UniSA. She's the Deputy Director of the Quality Use of Medicines and Pharmacy Research Centre, which is in Clinical and Health Sciences. She is on a lot of different subcommittees nationally around drug utilisation and the Pharmaceutical Benefits Advisory Committee. I know her as an absolute statistics wizard, but what I really value in Nicole's work is her very pragmatic approach to statistics and how she uses her biostatistics methodologies to make sense of complex data sets, but in a way that's really useful and impactful for patients and clients and health service providers as well. So without any further ado, I will pass on to Nicole and I will go on mute. So Nicole, if you want to start sharing the screen.
Well, that was a lovely introduction. Thanks, Susan. So I'm just going to talk to you today about some of the work we've been doing here at the Quality Use of Medicines and Pharmacy Research Centre around how we can use large healthcare data platforms to improve the safety and effectiveness of medicines, devices and vaccines. So I'm going to specifically talk about medicines, but we're also looking at devices as well. So to sort of set the scene, I'm going to tell a bit of a story. So once upon a time, way back in the olden days, it feels like now, back in March 2020, we had the COVID outbreak. And at that time, there were, reports coming out about different side effects of medicines and susceptibility to COVID due to, patients taking those medicines or due to their underlying condition. And here's a report that came out 13th of March saying, well, actually, some drugs called ACE inhibitors or angiotensin receptor blockers might change how someone's cells are shaped, and that might make it easier for the coronavirus to infect them, and if they do get infected, have more severe illness. So that sort of led to a statement by the American College of Cardiology and other clinical groups around the place, and saying, well, look, actually, there's not a lot of experimental clinical evidence demonstrating this effect, and we really need better research to, understand this problem. So the two questions that were really of concern here were, do these medicines increase your susceptibility to getting infected? And if you do get infected, do they make you have poor outcomes? So, of course, those challenges are what researchers love, and we had researchers all over the world analysing those particular questions. So when we're talking about healthcare data sets, there are many and they're varied across the world. And each of those data sets can be analysed, a question can be answered, but normally those questions are, you can compare, and you can compare treatment to people on other treatments. You can look at elderly populations, and it all depends on the data source, where it comes from and what it contains. So if you remember back to that earlier story I talked about, a couple of months later, another report came out and it said, well, actually, it looks like the risk of death is actually higher in those not taking their medicines. And now there's evidence to suggest that, certain medicines might be protective. So you can see there's a ton of different stories that come from different analyses. And this particular study was done in a Chinese data set. So is there a better way? Can we use healthcare data sets to inform healthcare problems in a more efficient and more robust way? So the work that I do is really looking at how can we harmonise data sources across the world to do exactly that. So can we take different data sources that have various different formats, that contain data of various different types and persuasions, can we transform them into a common data model so they look the same, they feel the same, and they can be analysed in the same way. So we translate data into a common format for storing those data. Then we also translate the data that's contained within the data sets into a common language. So no matter where we are in the world, we have data that is standard and can be analysed in the same way. So what that means, of course, is once we have data standardized, then we can have standard analytic methods that can interrogate each of those data sources with just one program rather than individual programs and individual researchers doing that work. And then we have a coordinated approach across those data platforms that have the same standard data, and then we can produce evidence to improve the safety and effectiveness of medicines. So that's really the platform that we've developed with colleagues across the world to actually address these critical healthcare questions of the day. So the community that we're working with in this endeavour is called Odyssey. Odyssey stands for Observational Health Data Sciences and Informatics, and it's really a worldwide effort, with many different countries and data sources across the world. This is a fairly old listing of data sources there, 2,500 distinct users across 6 continents, and that's well exceeded that now. And the vision is really to create a world in which we can use all of these healthcare data sources that are available to provide a comprehensive understanding of health and disease, and use a platform that helps us to generate that rapidly and efficiently. So the way it works is we produce a database which has standardized formats, and I said standardized vocabulary, and because of that we then sort of have a way of connecting different data sets across the world, and it's kind of like a travel adapter. We have a hairdryer here in Australia, we can go to another country, plug our hairdryer in using an adapter, and it's still a hairdryer and it works in the same way, and that's exactly the point of these data sources. And then, of course, because it's in one format, we can have standardized research output. The real beauty about this kind of process and what we've been trying to do is that we can now upscale data analytics to a level never before seen. I suppose it's a way of really investing into research and getting outputs generated quickly and efficiently. So the way it kind of the whole process from data to evidence is that we standardize our data, we standardize the processes used to analyze those data. So we have tools that can interrogate it, and they don't need to be written every time, and then we can produce outputs. And the interesting thing is that you can produce really simple outputs but have a really important public health message. So here, for example, we looked at what types of hypertensive medicines patients were taking across the world, and these are 3 different databases in 3 different parts of the world, and you can see that variation in healthcare is really quite stark in these pictures. So the inner circle there is the first line hypertensive treatments that people take, and as we move out we see the second and third line antihypertensive treatments, and they're very varied across the world, and that's really important when we're trying to understand the effects of medicines in the community, how they're used in context. So this earlier study we did was actually interrogating 11 different databases in 4 different countries, looking at this idea of how do people use antihypertensives, and it was done in 250 million individual patient lives. So you can see, doing this process really gives you access to these really large databases. Now that all happened in 2015, and we knew that there was, lots of different ways that people take their antihypertensives. And so when COVID hit, and there was this question about, do patients who take antihypertensive have an increased risk of COVID-19, we thought, well, here we go. We have the data, we have the databases in a common format, and now we can start to answer these really important questions of the day. So we actually did this. We got together as a community back in March 2020 for 88 hours, pretty much straight. So 3 days straight on Zoom, doing an analysis of data sets to answer this really important question that was occurring in real time. So we all got together, we asked the question, we did a study, and we called it the International COVID ACE Receptor Inhibition Utilization Safety, if I can say that correctly. So we had data sets. We had a data set in the US, we had a data set in Spain, we had a data set in the US veterans, which was already translated into the common data model. And then we did our processes and we produced an outcome. So the interesting thing with all of that is that we were able to publish that study in June. So we did the study together in April and then published it in June, and eventually got published in Lancet Digital Health. And we basically said, well, actually, there's no real evidence that antihypertensives are increasing your risk of COVID. So please keep taking your medicines and look after your health. And that was a really important finding for that time. I'm running out of time, so just quickly, we're also using that same methodology now to pivot our research and look at the safety of vaccines in COVID. And we're working on a project at the moment where we're evaluating methods for adverse event detection for vaccine surveillance. And again, we're using multiple different data sources. We're looking at multiple different vaccines and trying to understand how do we use large healthcare data sets to monitor vaccine safety surveillance. Lastly, I'd just like to, whoops, I should go back, sorry. Again, highlight that odyssey.org is the group that we're working with to do these studies, completely open, and hope people are inspired to take a look and get involved in this research. So, thanks, Susan.
Thanks very much, Nicole. That's, I froze for a bit there. That's great. You are 100% on time. So we have a minute or two for questions. If people want to put their question in the Q&A room, I'll just keep an eye on that. But in the meantime, Nicole, now I gather that your work is, has a lot of engagement activity. If people want to be involved, how can they get involved?
Yeah, so there's tons of opportunities actually to get involved. Email me, there's my contact address just there. But also Odyssey is a big community, it's a worldwide community. But in Australia, we are also developing a group called the Odyssey Australia Chapter, which I'm the president of. And what we're really trying to do is accelerate efforts in Australia to harmonise data sources that we have access to here, so that we can take advantage of all the tools that are available within the community. So go to www.odyssey.org and there's a ton of information there about how to get in contact with Odyssey Australia and how to participate in this research. And you don't need data to be involved in this research. You can actually come to it and help with methods development. You can help with running a study, posting a question of interest that you might have in terms of healthcare, and people in the community might help you to answer that question. So jump on and take a look.
What a fantastic offer. Thank you very much. And there was one question coming from Austin Milton. Very interesting presentation. In this latest study on vaccinations, are the AstraZeneca adverse events being studied as well? And if so, any word on that from you? Oh, I think Austin wants a scoop.
So actually, I haven't got results to share about the actual COVID vaccine. What's the work we're doing right now is looking at what is the what is the best method for identifying those adverse events? Because as you know, the vaccines are given selectively to different groups of people, and how do we actually unpack, the selection of older, sicker patients to certain vaccine varieties compared to others. So there's a lot of that background work going on at the moment to make sure that when we get access to these data with COVID vaccines, we're really interrogating the data set correctly. So no scoop to give you just yet. It's all a work in progress.
Watch this space.
Exactly.
Yeah, great. What a fantastic example of using data. I think it's really important for clinicians to hear that data that's collected on their patients is being put to use elsewhere in ways that they can't even imagine. So thanks for that, Nicole. Okay, if people want to get in touch, please do email Nicole. She's very approachable. And now it's my pleasure to also introduce another fantastic researcher from UniSA, Professor Carol Maher. She's Professor for Population and Digital Health in one of our research centres, the Alliance for Research in Exercise, Nutrition and Activity, also known as ARENA. Carol is a fantastic researcher in trying to understand how children and adults spend their daily lives, whether it's in physical activity or sleep or sedentary behaviour, and what impact that has on their health. And in particular, she's developed an international reputation in using wearables, using social networking, smartphone apps, and generally taking advantage of that technology that makes me feel quite old. So let's hear from Carol on her terrific work. Thanks, Carol.
Thanks, Susan. Yeah, so as Susan said, I'm really interested in people's daily activity patterns and the impact that has on their health and how we can help people improve their activities and health. So there's not enough time for me to get into how potent our activity patterns are on our health. But, I will say there's overwhelming evidence that, our physical activity, sleep, and to a lesser extent, our sedentary behaviour have really fundamental impacts on health and well-being and risk of developing chronic diseases. And in particular, if we can get more people doing physical activity, that would have enormous population health benefits. More physical activity is as potent as a lot of leading medications. But our challenge is how we get people to take it on into their daily lives. So today I'm going to just give you a flyby of a few of the projects that we have going on, just to give you a bit of the taste of the work that we're doing. And, who knows, maybe it might lead to some, new possibilities for collaborations. So the first project is an artificial intelligence virtual health coach that we developed. So this particular project arose through conversations with a colleague, Associate Professor Karen Murphy. So Karen specialises in the Mediterranean diet, and she's done some really fantastic research examining the physiological effects of the Mediterranean diet. But even though they've shown really fantastic outcomes from that work, that's been achieved through quite intensive one-on-one dietary counselling. And so, the challenge is that, that's really too expensive to scale up. And then if we combine that with a lot of the sort of more population level physical activity research that I do, we thought, there's an opportunity here to come together and try to develop a Mediterranean lifestyle intervening on both diet and physical activity using, chatbot technology, which, is a technology that we're seeing more and more in our lives, particularly in, say, online banking and online services. The little chatbot can pop up. It's a really fast and efficient way of helping people. And we're starting to see more of that being applied to health applications. So in this particular project, we worked with IBM to use IBM Watson artificial intelligence software to create Power. this virtual health assistant. And the structure of the program was that users would get an induction session with Paola, where she would teach them all about the Mediterranean diet principles, talk to them about increasing their lifestyle physical activity, teach them how to use a wearable, and help them set some goals for the coming week. Then from that week on, people were encouraged to check in with Paola at least once a week to review their goals and set new goals for the coming week. And also they could use Paola 24 hours a day, anytime they had a question that they wanted to ask her. So here are just some example questions. Will I lose weight? What if I don't like exercising? I've got a party, you know, how do I stick with the diet? And so on. So we have conducted a pilot study, and I guess the first thing was that we got terrific interest. We were inundated with people wanting to be involved in the pilot, which was a very refreshing change compared with a lot of studies we run. And we also had really excellent retention at 12 weeks. So in terms of physical activity, we got some really better results than we would often tend to see with our programs. We got nearly 2 hour per week improvement in physical activity across the program. We also saw quite dramatic improvements in people's diet quality. And then, not surprisingly, if you're doing more physical activity and eating better, we saw improvements in adiposity. So this wasn't a weight loss program, but we did get significant weight loss and significant reduction in waist circumference. Across that 12 weeks in our participants, there were nearly 4,000 conversations. And when we went back and looked through the logs, the bot replied accurately 96% of the time. So really, we're quite excited about the possibilities for this approach in future. You know, it could be deployed using smart speakers, extended to other health conditions. Yeah, really the sky's the limit with that. If only people would give us funding to keep going with this work. Okay, so the next study that I'd like to share with you is the ARIA study. So this particular study is focused on understanding the annual rhythms in our activity patterns, weight, diet, and well-being. So the reason that we were interested in this is the rates of overweight and obesity have increased dramatically. You know, 2 in 3 adults are overweight or obese. The rates are still going up. And now we understand quite well the demographic and lifestyle factors that feed into this, but we don't actually have a good understanding at all about whether particular times of the year are risk periods for weight gain. So some research has come out from overseas that shows that we do see spikes in weight at different times of the year. This is Fitbit data from Japan, the US and Germany. You can see in the US cohort, there's a little spike at Thanksgiving. In all of the cohorts, there's a spike at, you know, in the Christmas New Year period. And then, you know, there are different spikes around Easter, in the German cohort, in the Golden Week, which is one of Japan's major celebrations, and so on. So this really suggests that there are cultural factors at play when it comes to weight gain. But, you know, you might notice that all of these studies have been done in Northern Hemisphere countries where, you know, Christmas and Thanksgiving coincide with winter. You know, winter could be a period of weight gain. So we don't really know, you know, how cultural factors are interacting with climate. So we won NHMRC funding to run the ARIA study, where we're really intensively following people's activity patterns, weight, diet, and wellbeing across a year. So we're measuring weight and activity every single day using Fitbit wearables and Fitbit scales. And then we're doing very regular online surveys to capture diet and weight status. Oh, sorry, diet and wellbeing. Now, to do this, we worked with software developers to create some software that can automatically pull down people's Fitbit data. So it's really low burden for the participants. They're just wearing their Fitbit and weighing themselves every morning, and all of that data are coming to us automatically using this software. Now, I've just got some really, really preliminary results to share with you. We've only just got the first lot of data in. The data set's been a bit of a beast because we have data for every minute of every day for 13 months for all of our participants. So it's a very, very big data set. But we were excited to see that we can pick up some seasonal patterns in people's activity patterns. So you can see there's a real dip in physical activity around February. And also here sort of during winter, and whereas it kind of peaks during autumn and spring. Around 30% variation in physical activity from the peak to the trough. Also, I've got the weight data that I can show you. So you can see, compared with the yearly mean, we saw an increase in weight around Christmas, dropped off towards the end of summer, and then it picked up again in winter. And now, interestingly, we actually got a net weight loss over the 13-month period in our first cohort. Definitely weren't expecting to see that, because we know that on average people would usually gain about 0.5 kilogram a year. So it's likely that that's actually that the daily weighing has had a bit of an intervention effect on people. But I guess at least we still can see the seasonal change in weight kind of shining through with the gains at Christmas and winter. So those are just really, really preliminary results. Our next and final wave of data collection will come in by the end of this year. So then we'll have data from nearly 400 people. And so the final study that I'd like to share with you is this study looking at activity in healthcare. So, you know, we know that physical activity has really important health impacts, you know, in the general population across the entire lifespan. But there's increasing interest in how physical activity can be used as a form of therapy in clinical populations. And there's also interest in how active patients are in different clinical settings. And obviously there's quite a lot of concern about the decline that certain patient groups can go through when they're in hospital. So in this particular study, I've kind of over the last few years had various clinicians getting in touch or hearing about clinicians who are starting to use wearables in their clinical practice, but everyone's kind of doing it just in like little kind of fragmented efforts. So I'm really interested in trying to better understand who's doing this work and trying to bring everyone together in sort of a cooperative effort and see if we can come up with a more standardized approach. Obviously, there's a lot of exciting opportunities if we could get people doing this in a more similar way. So the first step of this is that we've undertaken a mapping exercise here in SA. So we wanted to understand who's using wearables in clinical practice, which wearable are they using, what are they trying to use the wearable for, how well is it working, you know, what's making it work, or what are the barriers, and really trying to get a sense of what people see as the opportunities for taking this bigger in future. So in this, we completed this research last year. And just sort of got to analysing it this year. But we identified 18 participants, but some of them were colleagues of each other. So it really represented 12 hubs of activity. Within those 12 hubs, they were using 9 different wearables, and they were using them for different reasons. So some groups were using them because they were wanting to measure the effect of some part of treatment. whereas others were actually using the wearables as an intervention tool. And we actually found that, thanks Susan, we actually found that a lot of researchers were actually doing this with kind of research motivations. So in terms of barriers, we found there was the clinician's time to use wearables. Wearables give a heck of a lot of data, and interpreting that data is difficult with all the pressures of clinical work. And then there was sort of more wide system level barriers, like the multidisciplinary team not understanding why the wearables were being used, and so on. And then enablers were certain characteristics of the devices, like if they had a good battery life, they were worn on the wrist, and having patients who were kind of on board. And in terms of opportunities, I think this is the most sort of exciting piece, is really there was a lot of optimism for the potential role of wearables becoming bigger in clinical practice into the future. However, there's clearly a need for guidelines to guide best practice in this space. And there's definitely exciting opportunities, for, creating like sort of centralized collection of data, in different patient groups and so on, if we can get to the point of getting people on board with following a more standardized approach. So we're currently doing a Delphi study, kind of taking it to the next step. So in summary, I've spoken to you about our AI health coach, which really had great interest from participants and has strong pilot results. We've used Fitbits as a research tool, and combined with that bespoke software to capture the data, it's really a very rich data set with low burden for participants. And then there's the wearables in hospital population study. And some other projects that I don't have time to talk to you about. We've done various projects developing smartphone apps, and we're really interested in creating a really positive user experience. We've done quite a lot using different social networks to deliver interventions. It's included using gamification, and also we've done some experiments using different online recruitment approaches for research. And when we're more and more getting into intervention scale up and translation. So that was a bit of a flyby. But if any of those things are of interest to you, please get in touch. Thanks.
Great. Thanks very much, Carol. Thanks, Nicole. So we won't stop for questions now, but Carol is very contactable as well. Please do get in touch. She's really approachable, has got some great ideas, is a great collaborator. So thanks for joining us, and see you all next week. Thanks, Tamara.